Asthma comes from the Greek word meaning panting. Asthma is therefore defined as a chronic inflammatory disorder of the airways, characterized by variable airflow obstruction that is often reversible, either spontaneously or with treatment. Asthma can be divided as either atopic or non-atopic. Atopic asthma is extrinsic asthma, meaning it is triggered by environment, and this type of asthma is the most common. Atopic asthma involves inflammation mediated by systemic IgE production. Non-atopic asthma, on the other hand, is an intrinsic asthma, and this far is less common. Non-atopic asthma therefore refers to inflammation and constriction of the airways that is not caused by exposure to an allergen. Initially, these inflammatory changes are completely reversible, but over the years, irreversible changes start to take place. That is, there is edema, scarring, and fibrosis begin to build up, leading to a thickening of the epithelial basement membrane, which permanently reduces the airway diameter. Although the specific causes of asthma are ultimately unknown, it's thought to be caused by a combination of genetic and environmental factors. Asthma involves these key pathophysiological processes, thus airway inflammation, airway hyperresponsiveness, increased mucus production, and airflow obstruction. Now, most patients may come with chief complaint of dyspnea, wheezing, and cough. So, what's the pathophysiology leading to dyspnea, wheezing, and coughing? So, if you take a look at the lungs, you've got a trachea, which branches off into right and left bronchi. And this continues to branch into thousands of bronchioles. In the bronchioles, we've got a lumen, the mucosa, which includes the inner line of the epithelial cells, as well as the lamina propria, and the submucosa, which is where the smooth muscle lives. Now, within the lumen of the bronchioles, there is bronchial wall edema because of the massive inflammation that narrows the airflow. So gaseous exchange is impaired because it becomes difficult getting carbon dioxide out and moving oxygen in. So this is actually one of the major reasons patients can have dyspnea, wheezing, and coughing. There is hyperresonance vacation because you're having difficulty getting air out because there is a lot of production of mucus. This is because the inflammation activates goblet cells and these start secreting mucus. The increased mucus production leads to bronchial wall edema. This makes it difficult to get carbon dioxide out and difficult for oxygen to enter. The air being trapped will cause wheezing, hyperresonance vacation because the lungs become hyperinflated. There is bronchoconstriction or bronchospasm within the smooth muscles of the bronchial airways. The lungs then become hyperinflated. So what leads to the bronchial wall edema, excess mucus production, and bronchospasm? Let's walk into the pathology leading to the increased bronchial wall edema, excess mucus production, and bronchospasm. So our first stage is the sensitization phase, which is the initial exposure to allergen. So asthma are usually triggered by allergies, and this is important in what we call the atopic triad. And this comprises of atopic dermatitis, asthma, and allergic rhinitis. Now, the triggering substance that leads to the asthma attack can differ from person to person, but some common ones include pollen, dust mite, pet dander, mold, car exhaust, and cockroaches. Medications like aspirin and beta blockers may also trigger asthma. Aspirin affects some of the inflammatory pathways, such as the leukotriene pathway, that may increase the amount of leukotrienes. There is also the SAM test trial, which says patients with asthma have aspirin sensitivity and probably also have nasal polyps. Beta blockers may also lead to bronchospasms. Another important factor that may exacerbate asthma is infections, and these are mostly viral infections. Excessive exercise and cold air may also trigger asthma. An allergen, example pollen, dust mite, and mold, enters the airway and is captured by dendritic cells. These dendritic cells present antigen to naive CD4 and then T cells within the lymph nodes. In asthma-prone individuals, these T cells will then differentiate into type 2 helper cells. This can lead to irreversible narrowing of the airways, especially within the bronchi, which causes symptoms like wheezing and breathlessness. They've got an immune cascade, and then this is common, especially in allergic or extrinsic asthma. So there is type 2 helper T cells response. So the Th2 cells secrete key cytokines, which include interleukin 4 and the others interleukin 4 do. IgE production by B cells, and this for allergic asthma. Then interleukin 5, this attract and activate eosinophils, which damage airway epithelium. Then interleukin 13 increases mucus production and enhances IgE-mediated response with airway hyperresponsiveness. These IgE antibodies bind to mast cells and then synthesizing them. There's also the rare exposure stage, and that's the asthma attack. So upon rare exposure to the allergen cross-links to the IgE on mast cells and leads to mast cell degranulation. So mast cells release histamine, and this leads to bronchoconstriction. Leukotrienes also increase vascular permeability and bronchoconstriction. Prostaglandins, specifically prostaglandin 2, augment the inflammation. Then we've got a two-phase reaction, which is the early and then the late. The early reaction usually occurs within minutes and is dominated by bronchoconstriction. Clinically, the patient experiences acute wheezing, tight chest, and shortness of breath. In the late phase reaction, which usually occurs within 4 to 6 hours later, there is infiltration of eosinophils, neutrophils, and basophils. There is sustained airway edema, mucus hypersecretion, epithelial damage. This phase contributes to chronic inflammation and airway remodeling. So with our last stage is the chronic changes, that's the airway remodeling. So in long-standing or poorly controlled asthma, the airway undergoes structural changes, including the smooth muscle hypertrophy. There is also goblet cell hyperplasia, leading to excess mucus. There is thickening of the basement membrane, and then subepithelial fibrosis from collagen deposition. These changes make the airways less responsive to treatment and contribute to irreversible airflow limitation in some patients. Now let's talk about non-allergic or intrinsic asthma variants. So not all asthma is allergic. Other phenotypes include neutrophilic asthma, which is common in adults and is less steroid responsive. Then we've got aspirin-associated respiratory disease. Then we have exercise-induced bronchoconstriction. The immune pathways in these variants may include T helper cells, which is 17, and then innate lymphoid cells, rather than type 2 T cells. Then let's talk about diagnosis. What do we do to confirm asthma? So we've got our common tests, which includes spirometry. So this demonstrates reversible obstruction, which is usually greater or equal to 12% improvement in FEV1 post bronchodilator. Then we have peak expiratory flow rates, which is also used for monitoring fractional acyl nitric oxide. So we have fractional acyl nitric oxide, and this indicates eosinophilic inflammation. Then you have methacholine challenge test for patients with normal spirometry but suspected asthma. What do we do in our management? So management, we have our acute management. In acute management, we can give our short-acting beta agonists. For example, is our salbutamol. We have anticholinergics. Example is ipratropium. We have systemic corticosteroids. Example being prednisone, which may suppress inflammation. Then we have chronic management. So this includes inhaled corticosteroids. Example being budesonide and fluticasone. We've got our long-acting beta agonists. An example is Symbicort. Then we have mast cell stabilizers also in addition. Then we've got advanced therapies. So advanced therapies, we have biologics for severe asthma and also as one of the management we may use. These are usually used in severe eosinophilic or steroid refractory asthma. Then let's talk about non-pharmacologic management. So you have to avoid triggers such as smoke, allergens, cold air, aspirin. Then you develop an asthma action plan. So personal with green or yellow or red zones. Then you develop some breathing techniques. Weight loss, minimal exercise, and some immunization will also help. So in summary, asthma is a complex inflammatory condition. It involves airway hypertensiveness, inflammation, and remodeling. Treatment range from inhalers to biologics. Personalized plans are key to long-term control. If you found this video, click the like button, subscribe to the Pulse Medics, and hit the bell icon for more evidence-based health education. Drop a comment below. What topics should we break down next?